the past years and the regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass.
Who's going first?
This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future if you want to have CME credits. Please do it through the all-access pass.
Okay. You want to go first?
And we're live in 5,
4, 3,
2, 1.
Well, good morning, everybody. Happy June 18th, 2025. And many greetings from the Seattle Science Foundation. My name is Jens Chapman, and today we're very excited about the topic of our STED Talk, Spine Technology Education, and the multivariant D, discovery, developments, in this case, discovery debates, which will not shortcut. So today we're going live to the University of Virginia and Dr. Stephen Lockey, MD, MBA, Assistant Professor in Orthopedic Surgery at the great UVA, one of our nation's leading institutions. And they're going to talk about something that is, in my eyes, as an aging spine surgeon, both fascinating and maybe a bit scary. So that's prone lateral interbody fusions. Dr. Lockey, good morning.
Morning, Dr. Chapman. Thank you for having us.
Good to see you. And we have Dr. Wang also, an MD, MBA candidate at Georgetown and a spine research fellow. So good morning to both of you. And we're looking forward to your presentation. But as always, we want to have your thoughts on some cases. I think we have 4 cases prepared, and none of them are curveballs, but they're hopefully serving as a suitable introduction for the D part in terms of debate. So without much further ado, Dr. Colin Gold is going to come up here, outgoing neurosurgical fellow extraordinaire. He's going to the University of Arizona, and he has put a case together that he thought was interesting to discuss. Colin.
Thank you. All right. So this patient is in her early 70s. She presented to clinic with progressive low back pain, bilateral leg pain, worse on the right than the left, and walking intolerance that has been progressive over time. Patient had an initial surgery, but pain recurred. That was done here at Swedish. Her full surgical history, she had an L3 to L5 posterior fusion done in an outside hospital 20 years ago. Developed spinal canal stenosis and neurogenic claudication, had an L2, L3, and L3, L4 laminotomy 2 years ago. Now is back with recurrent symptoms. Past medical history is significant for DVT history, anxiety and depression. She's a former smoker, is widowed, lives alone, but her son lives nearby. Her physical exam is really not significant for anything. Her only symptoms are pain, no weakness, or sensory changes. So here are some sagittals. This is the initial MRI when she first came to Swedish. So pre-L2, L3, L3, L4 laminectomy, but after, before she re-presented with recurrent pain. The middle scan is post-laminectomy MRI. So you can see she has recurrent stenosis at 2, 3, 3, 4, and progressive disc collapse, as well as foraminal stenosis at those levels.
So the center structures, the spinous process is still intact, as far as I can tell?
Yeah, so we have a CT as well.
Okay, oh yeah. So are her symptoms best described as neurogenic claudication or radiculopathy?
She has some of both. She has pretty significant walking intolerance as well as radiculopathic pain in both legs. And you can see foraminal collapse on both sides at 2-3 and 3-4.
So Dr. Lockey and Dr. Wang, full disclosure, I don't know those cases, so I'm very curious what was done here, but all too common, nicely done fusion 4-1, no question about reasonable alignment, solid fusion, safely placed hardware. And Colin, one more time, how many years, what's the interval of this degeneration, the adjacent segment disease and decompression, and then what's the interval from decompression to more manifest definitive treatment?
Yeah, so fusion 20 years ago, L2, L3 laminectomy 2 years ago, and was good for about a year, and then had recurrent symptoms.
And so walking and talking, so this fits the neurogenic claudication plus a mechanical component. So Dr. Lockey, this is, I'll start with you here. This is an all too common phenomenon, it's almost expected. There were previous decompression attempts done, which I personally think are very reasonable to try to address the neurologic component. There's now a stable appearing grade 1 degenerative spondylolisthesis. There's a 2-level adjacent segment disease. The patient clearly, I think we can agree on that, needs a repeat decompression. Is a fusion inevitable at this point in time? And if so, how can you do that with the least trauma, not just to the patient, but the surgeon, while not going through the old laminotomy sites?
Yeah, I would agree with your initial assessment, Dr. Chapman. The index fusion performed 20 years ago it looks, the alignment is very favorable. It looks like a solid fusion and speaks to the durability. You know, so one of the things that I'll just mention that drive me crazy though is all this discussion about pre-contoured rods and how it eliminates adjacent segment issues because we get patients into optimal alignment. It may limit it, but ultimately the spine was never meant to be fused, right? So as you mentioned, eventually the adjacent segments are going to break down. I think an adjacent segment decompression to start with, somebody who has neurologic symptoms was totally reasonable, but at this stage we're looking at a fusion. And I think, you know, ultimately, however you want to do this, the nice thing is the base is done well. You're not looking at a 3-column osteotomy to get her corrected. So if you want to do something that's a little bit less incursive, I'd have to look at her axial MRI to see how favorable her retroperitoneal space is. A lateral is certainly an option, but also a very traditional open posterior T-lift to address this. And I think you're at least going up 2 segments. I'd have to look at her scoliosis films to see what her overall alignment is.
So it's nobody's cup of tea to go back through a old laminotomy. We're accompanied here by Drs. Covey and Dr. Martin from Tacoma, Washington, 2 very esteemed spine colleagues. Revision surgery, in this case a revision surgery of 3-4 and 2-3 seems inevitable. What are your thoughts on going back through the scar, decompressing it, doing a T-lift like what Dr. Lockey said, or is an oblique anterior or a far lateral approach something that you'd prefer to stay out of this scar area? So Dr. Covey is giving the microphone to Dr. Martin, very gentlemanly.
I would personally go through and posteriorly do a T-lift. I think if you're comfortable going lateral, I think restoring the lordosis and getting some distraction across the site may be enough to decompress. But I would go in and do T-lifts. I'd go on the side that's tightest, taking off the posterior elements on that side. Release as much of the disc as possible, get a expandable cage, really trying to get big footprint and increase the lordosis at those 2 segments. I'd stop. I just do 2 segments. I go 2 segments above. And, you know, if I had to, you know, dig through the scar tissue on the other side to open up the foramina to make sure that everything's opened up, I would do that. For better or for worse, this is probably 75% of my lumbar practice right now is this sort of thing.
It's a new specialty, isn't it? Revision spine surgeon.
Yeah. Got
Dr. Covey,
got one tomorrow.
Any contrarian thoughts to that?
Yeah, I think the difficulty is just a little bit where to stop in this one. Is L2 a good place to stop? The L1-2 disc didn't look all that great, so do you have to go farther? But I would definitely choose a T-lift approach as well.
So Dr. Lockey, you're going to talk about indirect decompression, I'm sure, in your talk. Is this a spine that is conducive towards indirect decompression? Looks pretty grotty to me, as the Brits would say. So L3-4 looks pretty socked down with osteophytes and scar. There's a little bit of air in there. But can you reliably, in a post-laminotomy case with this kind of, especially at 3-4, Dr. Cole's putting that up again, socked down adjacent segment, actually get an indirect decompression? And that's the second question in a second.
Well, Jens, I have to tell you, in putting together this talk, I was trying not to disappoint you too much, because I know your feelings on the going to the retroperitoneal space, and you know that Steve Ludwig trained me. I'm very traditionally trained, so it's all starts with the neurology. You have to decompress the neural elements, otherwise, what's the point of the surgery? For me, I think this is controversial, right? I think a lot of people are really are advocates for indirect decompression, not just of the neuroforamen, but of the canal by placing tension on the ligamentum flavum. I don't traditionally use this technique to achieve those goals. I mean, I think you're using, in this case, if you're going to do a lateral interbody technique, you're using it for anterior column support, restoration of alignment to achieve fusion. You can't get away from actually visualizing and doing a direct decompression, particularly when somebody comes to you with leg pain. Your job as a spine surgeon was beat into my head. Someone comes to you with leg pain, you have to take it away.
So now, Colin, I'm going to ask you the next question. So you present a lady that's in her 70s, ex-smoker, osteodensity I'm not totally sure about, doesn't look like super healthy bone outside of the sclerotic margins. Any thoughts about bone density? And can we, through an anterior column reconstruction, hope to actually get a lasting elevation of the bone, the anterior column?
Yeah, especially at the upper level, I'd be concerned about that. As you said, it's so sclerotic, those end plates at 3-4. Maybe fusion could be more of a problem, but it seems like it's going to be hard to break through that end plate. But 2-3, a little more concerning. She hasn't had a DEXA anytime recently.
So we're operating on her without a DEXA?
Yeah, she hasn't since prior to the laminectomy.
Wow,
She
okay.
had the DEXA.
Yeah, I definitely recommend at least Hounsfield unit measurements at L1 or something like that. But she does look a little bit osteopenic. Tell us what's happened.
All right. So surgery was L2, L3, L3, L4, interbody, left transpsoas approach. This was standalone lateral interbody fusion. So post-op, patient was discharged home without any complications on post-op day 2. Her most recent follow-up was 5 months, in which she's had significantly increased walking tolerance, and then her back and leg pain have both completely resolved. Here are some post-op MRIs.
So this is beautifully done. And how large are the cages, especially at 3-4?
I believe these are, the upper one is bigger, I think, or actually they're both either 9 or 10.
Are they expandables?
Yeah, This one clearly expanded more, that's why that look different.
So this is obviously highly technique dependent, and the surgeon who's not here in the audience today was able to get largely bicortical purchase, meaning from left to right vertebral body, to get this together. The lordosis may have not been perfectly restored, but the indirect decompression sure looks impressive. So she did it okay.
Yeah, she's doing well, 5 months out at least.
Dr. Lockey, what are your thoughts on this? Did the surgeon get away with something lucky? I'm not going to identify him here. And should the surgeon, all this turned out well, have added a side plate or screw fixation to this construct?
No, I think this is obviously a great result, and I wouldn't say lucky. You know, this technique is great when it works well, and I think it can work well the majority of the time. It's when it fails that we ultimately have a problem, and I'll quote our division chief on that later. But no, I think this is a good result. It was a low morbidity procedure for her, and overall a great outcome. The one point of caution I'll say about placing plates, which I do on occasion, is it's more hardware. And if you do get a subsidence, or you get into a situation where you're in a revision scenario, that makes the next operation more difficult. And I think for the young surgeons, I've only been in practice for 2 years, but depending on where you end up, you have to always be conscious of the next operation. And you should be thinking about that when you index a primary, or even when you go back on a revision. What's the next thing I'm going to do, and how can I set myself up for success? So if you have a good press fit on these lateral interbodies, you feel like you have good stability. I don't think a supplemental plate gives you anything.
Dr. Gold, in your practice in Arizona, are you going to put supplemental screws into the back in a situation like this? If this was your gestalt, your dictum?
I would have done posterior here, but
Yeah.
or I will in the future. But yes, if I ever do any kind of lateral fusion, I'm putting screws in from.
So this is totally anecdotal, but I could probably pretty effortlessly pull them out of my Epic files because I've collected them. I've had several of these standalone laterals in very similar patient clienteles where the vertebral bodies above just basically go into this anvil, kind of a pincer burst fracture. The cages subside, they tilt, and they kind of collapse down. So I'm amazed and impressed with this, but verdict from your end? Dr. Scovey, Martin, Lockey? Great execution.
No, it looks good, great execution, and people that I know who put a lot of these in swear that the reduction is adequate, opening up and decompressing the canal. I just don't do a lot of them. Just not to throw shade on this, but it's 5 months down the road.
Yeah,
The race is not run yet.
Yes. So next we have thank you, Dr. Gold. Next we have Dr. Cameron Hogshead, and he has just signed a contract, and he is going to enhance the spine health of the good people of Tampa, Florida. And there's a hotbed of ex-fellows down there. We can't wait to hear how he's doing there. And this is a little bit more complicated case.
Yes, thank you for the lovely introduction, Dr. Chapman. This is on the subject of anterior surgery and revision surgery, a 55-year-old female that presented with really worsening, debilitating low back pain in the last year, that also had pretty bad bilateral lower extremity radiating pain after probably getting around for 1 or 2 blocks. So the pain radiated into both hips and down the lateral legs. She had tried extensive amount of physical therapy, meds, narcotics, epidural steroid injections that just didn't give her lasting relief. You can see her lateral standing x-ray that she presented to clinic with a relevant past surgical history here. She had this fusion done in 2021 that was actually complicated by a right iliac artery injury and retroperitoneal bleed. You can see a coil just below her sacrum there that actually required an ICU stay and vascular intervention. She stayed in the ICU for, I believe, 3 days after this. What was told to her would be a reported outpatient same-day surgery. Past medical history, she's got chronic kidney disease and some depressive disorder. Social history is unremarkable.
Doesn't look so hot. Do you have neuroimaging?
Yeah. So these are her exam was essentially, besides physical pain reproducing maneuvers, benign. These are her flexion extension images. We have upright, no gross instability noted on flexion extension views, but she's got that static grade 2 anterior listhesis at 4.5.
So
Getting to our neuroimaging.
Yep.
This is a CT scan, and she's got parameters that are listed below that she was left in. There you can appreciate bilateral pars fractures at L5 as well, just kind of around the origin of those cortical screws that were placed.
There's a lot to unpack here. So we have end-stage disc degeneration 5.1 with a grade 1 isthmic spondy, which may have been secondary to the pars screws, something that I had not seen like this before. And then L4-5 malunion, non-union, with possible screw loosening at L4. And recurrent neurologic problems with the ongoing olisthesis at 4.5.
Right.
So
That L4 segment and some kyphosis there too, and then very subideal spinal parameters.
relatively young patient, Dr.
Relatively
Lockey. What happened and how do we undo this?
This is
There's a little iliac artery injury also, not to forget.
yeah, this is a bad problem. So I think that Dr. Chapman, you've talked a lot about this quest for MIS, and the problem is we're seeing a lot of people set up with pretty bad instrument of fusion where their alignment parameters are off, and it tends to occur down to the base of the spine. These cortical screws, that was a stress riser. This was just an accident waiting to happen, now having bilateral pars defects. And the challenge now being the iliac artery. This traditionally would be a nice revision. It looks like a pseudo at 4-5 if you're going to go back in, start in the front, do 4-5, 5-1 anterior. But I think, with that iliac artery injury, that may be prohibitive. So you're looking probably at an all posterior based approach. And then there's a coronal plane deformity. Young person, how high up are you going to go here? You might just start with the base and try to get that addressed. And just do 4-1, 4 to pelvis TLIF.
Doctors Martin and Covey, just a tangential but critical aspect in this fusion. So when we look at macro data, the vast majority of fusions in the US in the lumbar spine is done at 4-5, followed by 5-1. This patient had what looks like a pretty standard grade 1 degenerative spondy at 4-5, end-stage spondylosis at 5-1. What are your thoughts on including routinely such a level at 5-1 as a base where you have a lot of arthritis and wear and tear? It may not be the preeminent problem, but is it sensible, in other words, to do a 4-5 fusion on a very degenerative 5-1 base?
I would personally do that because the problem is, of course, you never know how a patient is going to do. If they have residual symptoms, you're going to think I should have included that level. But you can imagine that if a patient has primarily neurologic symptoms and has little to no back pain and is a 4-5 degenerative spondy, then that might be a situation where it's reasonable to just focus on 4-5.
Same thoughts, Dr. Martin? So 4-5 alone, okay with the actively spondylotic 5-1 segment?
Yeah, I've gotten more aggressive actually doing 5-1 the further I've gotten down the road in my career, because I think that someone who's active and you give them a good solid fusion at 4-5 and you're restoring their lordosis, I think that's just asking for, early trouble at 5-1. I think they're more likely to have a good long-term outcome with a less chance of an intermediate surgery at 5-1.
Dr. Lockey, 5, in retrospect, 5-1 inclusion, yes, no?
Yeah, it's amazing. All my mentors who have said the same thing as they get more senior in their careers, the going to 5-1 has become more common. And I think that speaks to the wisdom of time and practice. I think in general, when you start, surgeons don't like going to 5-1. It's hard, right? You're kind of you're working at an awkward angle, and there's a lot of pressure to get 5-1 right. If you don't do a good disc prep and you don't get the alignment right, you really set somebody up for a bad iatrogenic problem. So I think you probably see a lot of young surgeons would say, just do 4-5, treat the neurologic symptoms. And then with experience and time, more people are doing 4-1.
All right, Dr. Hogshead, we can't wait to see how this malunion, non-union two-level problem was revised with an old iliac artery injury.
Right. Just for completion's sake there, you can see axial MRI and vascular anatomy as well. This was reviewed with our vascular surgeon here, who has been highly skilled and a huge asset for us. And he actually felt comfortable with going forward with an anterior approach. And so
that's great.
We attack this with a back approach, mainly starting back first before a quick flip, just to remove the set screws and the rods. We felt that there is literature out there that you can go front and overpower a posterior mass and posterior rods and screws, but felt like in this particular situation there may have or may not have been disc space fusion. Looked like BMP bones when we went in from anterior, so we're really glad that we took those out posteriorly at first, and we took the cage out from the front and essentially ended up with a partial corpectomy there just to remove that cage. It was embedded in a BMP type fusion bone, and so osteotomes were used to remove that. And we were able to satisfactorily get pretty good release after an extensive amount of work posterior at that 4-5 segment.
So my bias is to go all posterior in these, but I applaud you and the attending surgeon for this work. This was a long case, right?
Yeah, this was a whole day affair.
Back. Yeah.
Yeah, this was a whole day affair.
So double flip, each flip is about an hour?
Yeah, the first one was we had the A-team in there, and then by the end of the day, things started to progressively slow down, and so, yeah, it's ultimately the incredible amount of time added from.
So this will pertain to Dr. Lockey's and Dr. Wang's presentation shortly, but I got to spend some time with Professor Jürgen Harms in Germany, and he had a timer set the second that the dressing was slapped on the backside. He had the timer put on, and if he had not cut skin by within half an hour, he would get not very friendly, let's put it this way. The German timekeeper came through, and he was actually, to his credit, in the room, helped flip. I mean, he would literally just dump the patient, shove them over, and get increasingly frustrated as the timer was winding down. How was the artery exposure? Was that an issue, or was it a non-factor in the hands of an experienced vascular surgeon?
Fortunately, it was a non-factor, and it was fairly smooth. There was some extra adhesions going through the approach when you're getting closer to the spine that took some extra work, but she did very well. No recurrent vascular injury or complications this far, and left the hospital uneventful.
And 4551 is always portrayed as such an easy exposure. Did you have to do the two-window approach, so through the bifurcation then lateral? So you had to do a full bifurcation dissection? Yeah. That's something that I always have to say. I've done these fairly extensively, and I try to avoid them because it's a substantial retroperitoneal scarring that's after that. You have to dissect out the entire bifurcation. You frequently have to vesiloop both vessels and the bifurcations, arteries and veins. That's an oncologic procedure. This is not straightforward. What do you think? Any thoughts? It was nicely done by our colleague, but that's a yeoman's job.
Yeah, that's impressive. Just having a skilled vascular surgeon who, is comfortable doing that is invaluable. I think you got much more support and better correction than you could even with, the latest expandable cages. So yeah, kudos to you, and that's a tough day.
Yeah.
Even when you're in your 30s, you feel tired when you get home.
Absolutely.
All right, any insights from you? What are you going to do in Tampa? Are you going to tackle this front back in your first month after arrival there? Hey guys, I have an 8-hour procedure with 2 flips. I'm going to put the Harms timer on the wall.
Tell him I know a really good guy in Seattle.
All right. But, I mean, the patient did well, right?
She did very well. Yeah, no dural tear, no leak, staring at the dura from anterior because that cage was actually in the foramen. So we got lucky.
No, it's not lucky. This was well done, well thought through. Very big effort, but nicely done. I would have done this all posteriorly, but that's okay. We can't beat this.
Yeah, thanks.
Thank you, Cameron. So next, we have our future partner, Dr. Mark Kramer. And Dr. Kramer is a neurosurgical colleague originally from the University of Wisconsin. And he's taking the leap to stay here as an attending. We're very excited about him. And he has something that we're also seeing more and more commonly here, and that is victims or recipients of microbiologic disease secondary to poor lifestyle choices.
Exactly. So not necessarily in keeping with the theme for today, but I promise you at the end, maybe a little twist back to it if we have time. So in this case, a 55-year-old woman, she presented with primarily neck pain and multiple falls. Symptoms were progressive over the last 2 weeks, but potentially longer. Bit of a poor historian. Also notable left arm weakness, lower limb weakness, kind of diffusely, numbness and tingling arms and legs, hepatitis C, IV drug use, unhoused. Here's her exam, a little weaker on the left and the right, but pretty diffusely weak throughout, a few pathologic reflexes, and but totally no bowel or bladder issues. So this is the MRI that was initially obtained. And you can see here a quite severe cervical kyphosis, and there's a retropharyngeal phlegmon versus abscess at C5-6. I also include the thoracic, which was clean, and then in the lumbar, you can see L1-2. There's some obvious infectious process at that level, as well as 5-1. So here are the 2 CTs that we obtained. Again, you can see reversal of the normal cervical lordosis and some essentially destruction of C5 and C6. The axials also, which I don't include here, show that phlegmon and that retropharyngeal, a large mass abscess at that level as well. And then the lumbar CT as well shows that end plate destruction at L1-2. Again, to reiterate our site score, which is developed here in-house. Again, looking at the 5 different items in regard to surgical decision-making. She had motor dysfunction, it's the junctional region. She had stenosis, of course, with impingement and myelopathy symptoms, pain with standing and falls. And of course, she has diabetes, IV drug use, no history of diabetes. So that puts her well within the surgical category. So just to pause here briefly, what are your thoughts, I guess, initially, and what do you tackle first? And what would your approach be?
So I'll deflect to Dr. Minisali. So this side score, thank you for showing that, has been very successful and has recently been validated by our Philadelphia Rothman colleagues in a nice publication. So this is a lot of hard work from a previous generation. Non-contiguous vertebral osteomyelitis discitis. You're looking at this, Dr. Minisali, without this being in the peer-reviewed literature. I'm going to give you my microphone. What are your thoughts? Is that a more severe thing, and any insights in prioritization?
Yeah, thank you. So we're currently studying this and how to apply the site score to multifocal disease. But in general, there's literature to support that these patients are obviously much sicker, higher in-hospital mortality rate. And obviously, she's kind of headed down the path of significant weakness. And so it's quite a big problem. And again, they're generally sicker and have higher in-hospital mortality for sure.
Dr. Lockey, are you spared from this epidemic of discitis osteomyelitis at UVA, or is this a burden to the patients and the good people of Virginia as much as it is here?
I don't think we see it as much or nearly to the severity that you see out there, but we do see it. I have a patient now with it, so it happens, and this is a challenging problem. I think you're looking at somebody who's sick, and the key is get source control, protect neurologic function. I think you start with the cervical spine, and you're looking at a front back circumferential fusion, and then I would come back at a later date and address the lumbar. I mean, I don't. Some people make an argument to do it all at once, but I think that's a lot of surgery for somebody who's ill, and the key is the cervical spine here first.
I'm not going to let you off the hook that easily. So when you say cervical spine first, totally agree. Yeah. Would you start this anteriorly first because processes, and then put a plate in there and a metal cage, or would you do posteriorly first?
I would do the anterior first, and I would put it. I don't hesitate as much in infection to place metal. I think infection does not like stability. That's what we knew that from the old POTS literature. Fusion was the treatment for tuberculosis. So if you can get rigid spinal fixation and good biology and antibiotics, I think it'll clear infection. So I probably would do a 2-level corpectomy and a plate with an expandable cage, and then flip and do the back and bridge it, circumferential fusion the same day.
So we live in a geographic area called the Puget Sound. It's a large ocean inlet in the Pacific Northwest corner. And the South Sound area, so around Tacoma, is that a similar problem? Do you get these patients just in droves like what we have? What are your thoughts? And so here you've done a nice charting, mapping of the spine. There's preponderance of neck disease followed by the upper lumbar disease. What's your triage, and would you go anterior or posterior? Would you stage it, or would you try to do it the same day?
Yeah, this is something we see all the time. I don't think a week goes by when we're on call that we don't get at least one patient like this. I think the incidence is actually decreasing over the last few years. I don't know if they're all just dying off, but so I would do the neck first. I would do a 2-level corpectomy. I like bone up front, but I think you get better fixation. You can dial the alignment better with a metal cage up front. I think you have to go from behind. She's going to need a long laminectomy and a C2 to T2 instrumented fusion posteriorly. I agree with leaving the lower stuff alone, let her recuperate, give her some IV antibiotics for a while, and then address the lumbar spine at some is yet to be defined future date.
So the regional expertise is very similar. Mark, what were your thoughts? You saw the patient. I know it's not my patient, but our colleague, Dr. Askuian, I think, took care of the patient. What was the thought in terms of how to proceed and neck versus thoracolumbar spine?
Yeah, so neck first. Yeah, she had myelopathy, and her neck was her primary complaint, frankly, although the back remains an issue. So we tackled the neck first. Contrary to, I guess I can jump forward here. I guess contrary to what a lot of folks said, we actually tackled the back first. We went C2 to T2 and actually got a very reasonable correction, C2 to T2 initially. And then we did end up going from the front the same day. We did a corpectomy, C5-6. It was a challenging exposure. The longest calli were incredibly edematous and swollen, and there was essentially no bony landmark at C5 or 6 to actually identify in the midline. So we had to go superior and caudal to kind of get our midline. And then given our concerns about fusion, given her tobacco use and other things, we had ultimately decided to do ACDF at 2.3 and 3.4 as well, which we were able to do very easily through the anterior approach once we had our bearings.
So this looks nice. We're talking about anterior and posterior, so I think that we actually discussed this case beforehand. I totally concur with going posteriorly first. The only question that I have is, so there's the subluxation still at C3-4. How's she doing neurologically, and was there any consideration to then do a corpectomy of C4 also, just having one strut graft run basically C3 down to C7?
Yeah, I mean, I think in hindsight, I do kind of wish we had actually taken out C4 as well. That being said, though, we actually, it probably doesn't show well on this CT, but the alignment actually was quite a bit better. So we're actually overall very happy, and we got a little bit of reduction of that 3-4 spondylolisthesis as well. I guess the last bit, I guess the last learning point for me in this case too is we don't do a lot of these, but if I didn't show this previously, but the left vert was also anomalous. We didn't feel like we could get a safe C2 pedicle screw in there, so we ended up doing a laminar screw.
I think that's great planning and great foresight. While you could argue about putting a C2 pedicle screw in that very narrow kind of a pillar there, this is definitely a highly anomalous, dominant looking left-sided vertebral artery. So I think that this is very good foresight. And how was the purchase of that translaminar screw?
Very good. Yes.
So the same question as for Dr. Hogsett before. So this was posterior anterior surgery in one day. How did that go?
It's a long day. The flip takes time.
So how long was that, just roughly? Hour?
Probably about an hour,
Yeah, no Dr. Harms. The other question I have is staging. So when you do a pretty big posterior surgery, you mentioned that the longest colli was swollen up. The anterior soft tissues, the retropharynx, swells up quite a bit. So I've done a fair number of these osteotomies in the past and still do them occasionally. But is there any thought to not rushing into the front part and just kind of getting it realigned, getting it decompressed, and then coming back to fight the anterior battle a couple of days later?
Yeah, I mean, I think that's the bonus, I think, to doing the posterior first, is that you got her at least stabilized, and if your alignment, if you're able to get a kind of a good correction for alignment from the posterior alone, if you're having issues that day or she's unstable, you can always kind of back out and kind of come back another day and do that anterior, or rebuild the anterior column. I think that's definitely a huge benefit to doing the back first. I think staging these would be a very reasonable approach as well.
Okay, if I ask a question?
Lockey, you've seen how this is handled here, and again, posterior and anterior same-day surgery. So it's, as Dr. Kramer said, a pretty big time investment, effort investment, and you're doing a very precarious surgery in the front of the neck later in the day with swelling, in addition to an already compromised host. So any thoughts? What would you do differently as you see this now? You have the hindsight of Wednesday morning quarterbacking, so.
I think it's very well done, and I think the point is very astute that if you got the alignment you needed and you got decompressed and instrumentation, you could always come back and do the anterior another day if it's getting late, which is safe for you, safe for the maybe an increased margin of safety for the patient. I do want to ask, because I think we present these cases, and I just am curious about workflow. Kind of two questions. If you didn't get the alignment you wanted when you positioned her prone, were you prepared to then stop what you were doing and not proceed and go anterior? That's number one. Number two, if you did get the alignment just with head positioning that you liked, but then you had a change in data in your neuromonitoring, what was the next step? Would you proceed it and just try to get the decompression as quickly as possible? Would you take her out of positioning and proceed with the front? These are always things that go through my mind when you're getting ready to do a case. And what am I going to do if I lose data? And I'd be very concerned with this, right? You're doing a sort of a closed realignment before you begin the case. What would be the next step for you?
Yeah, that's a great question. I mean, I guess it depends on where you are in the during that posterior approach. I think decompression would be paramount if you are seeing changes in monitoring. So, zip off the lamina, decompress everything. Depending on where you are with your instrumentation at that point, you can always kind of, at that point, kind of reassess, depending on how your monitoring is going, how the patient's doing clinically. I think certainly, in this case, we did use monitoring. Oftentimes, these infection cases, we don't, just because there's additional risk for everyone involved in the case. But it's a great question. I don't think I have a perfect answer.
So let me answer both of those. And I was not involved in this case, which was very nicely done by one of our partners. I would have high confidence of being able to get a posterior reduction, or at least a reasonable reduction in this kind of a setting. And it'll take maybe even a lateral mass resection at C3-4 specifically to kind of get this mobilized enough. So that'd be my escalation after getting really high quality rostral and caudal control to then resect the lateral mass, and that allows me to then, with 4.0 rods, to pull the neck back. I might even have to do the laminectomy first to then get this pulled back, but I usually keep the spinous processes intact, put a spinous process clamp on there, and then can translate it through that before I take that off. So that's a reduction aid. I usually don't use neuromonitoring in these situations because of the risk-benefit assessment. And again, my thought is I'll be as careful as possible, but I got to do what I got to do. And again, this is where gets a very lengthy case with a lot of extraneous things, and we got to get the job done somehow without being reckless, but very careful. The question, I'm going to go back to what Dr. Martin said earlier, that I still think it was reasonable is in the beginning, going from the front and putting an allograft in there with a plate and letting the patient rest for a couple of days. I would have probably taken one level higher, so C3 to C6, and made sure I had bicortical screws with that. My problem is I've done this on one occasion where I was so happy with my reconstruction result. I put the patient in a collar. She did so well. I did not fuse it posteriorly, and then half a year later, the whole construct fell apart. And we had to do a very heroic revision surgery. So I sweet-talked myself into, maybe we don't have to do it from the back. And I got such good fixation, and just wanted to offer that as a caveat. So. But a very thankless population, very big investment of society and the surgical team into trying to restore this. And I think what happened here was very good. Are there plans to fix the thoracolumbar junction, that L12 zone? I forgot the level.
So that is actually the question. If you go back to my slides, we have not addressed this yet. We have a bug. It's a kind of a strange bug, actually. It's a Corynebacterium diphtheriae, which is a kind of a oral.
Which one? Sorry?
Corynebacterium
Corynebacteria,
diphtheriae, which is a strange one I haven't seen before recently. But so we have on IV antibiotics. She's actually doing reasonably well at this time. Pain control has been an issue, obviously, but going back to our discussion of whether this is something you could do through a lateral approach. I know the lateral approach was initially developed for POTS diseases. Would this be anything you would potentially attack from a lateral approach? L1 too.
Dr. Lockey, wait and see or do a prone lateral?
No, I would wait and see. I would see how she does on antibiotics, watch her inflammatory markers, let her recover from the cervical. I get very concerned about doing anything in the retroperitoneal space in the setting of infection or a major inflammatory process. The vessels can be very scarred. You can have aberrant anatomy. It can be easy to get lost and off axis. That's when you get into trouble. So if you're going to treat this, do it from a posterior approach. I don't see any reason why you don't just do it in more traditional methods.
Great. Okay, one last case. And this is going to be a nice segue. Thank you, Dr. Kramer. Well done. Dr. Nick Minisali wearing his Philly lanyard again proudly. It's almost football season, right? Mm-hmm. So Dr. Minisali is going to go to Delaware. He has a very nice practice location sorted out there, and he's going to show a case that'll lead us straight into your talk.
Yes, thank you very much. All right. Is that showing up okay?
We need to do a little AV switch. I want to thank Corey and Hannah for always watching us. Do we have to mirror?
I'll download it. And then...
Is it a Philly blocker?
Download. There we go. Sorry about that.
Let me ask a question going back to the case that Dr. Hogshead showed with that collapsed 4-5 cage. Dr. Lockey, is that something that you'd be comfortable removing from a lateral or far lateral approach? Does that patient with that 4-1 or 4-5 fusion, malunion, non-union, is that something you'd be comfortable fishing out from a lateral approach?
No, I think that's I'm either going to take that out from the back or from the anterior.
Dr. Lockey. Yeah.
Can you hear me now?
Yes.
Yeah, no, I would not take that out from a direct lateral approach. I'm taking that out either posterior or anterior as it was done very well in that case presentation. I think you have to gain control. You're working through a narrow window. There was a component I overheard that it was in the neuroforamen. There's just not a high enough margin for safety there in my hands to not do it with better direct visualization.
Great. Dr. Minisali is ready to show his case, the segue case.
Sorry for the delay, thank you. So this last case is a mid-50s-year-old female with low back pain and left leg pain, radiculopathy in approximately the L4 distribution. This does get better with laying flat, and she notes it's worse with standing and activity. She does independently ambulate, but sometimes needs a walker with a seat to sit down. She is a controlled diabetic on Ozempic, past medical history of depression, and her BMI is around 32. She did have a prior L5-S1 ALIF back in 2005 at another institution, non-smoker and no alcohol use. Pre-op exam, she's intact as far as motor sensation. Again, pains in that L4 distribution, and she's failed years of non-operative care, including injections, PT, activity modification. Here we can see her dynamic lateral x-rays, the lumbar spine with their prior L5-S1 interbody fusion, and then unstable degenerative spondylolisthesis at L4-5 with overall maintained lordosis and alignment. There's really no lumbar lordosis PI mismatch at this point, and her L4 to S1 angles 40 degrees, which is appropriate. Here on her axial and sagittal MRI, we see the reduction of her spondylolisthesis. So compared to her standing films, we know that this is unstable. Again, we see significant bilateral facet edema at L4-5. And again, because of this is reduced, there's no significant foraminal or central stenosis on the MRI. Just as far as background, she had a DEXA 6 months prior to visiting us. That was normal, so no osteoporosis or penia. So a little more straightforward case for you, Dr. Lockey. Mid-50s, long-term low back pain and radiculopathy and an L4 distribution on the left with an unstable spondy after a prior fusion in 2005.
This is
Dr. Lockey, pretty nicely maintained disc integrity, but sagittal translation, some loss of lordosis, and the denuded facet sign with the facet fluid sinus pattern that pretty much shows that there's a facet incongruence at this point in time, and some more lateral recess, what I would say stenosis with some foraminal stenosis, not so much central. Right. So clear indication for fusion. Any thoughts on how to put these variables I just described together in an action pack that is somewhat evidence-founded?
I assume the 5-1 looks solidly fused. You get a CT scan, yes. And that's so this is a great case. And I think from my training, despite I don't love relying on interbody technology for indirect decompression, she's telling you in the history, and you could anticipate on the MRI after that, looking at the X-rays, completely asymptomatic when lying flat, and when the spondylolisthesis reduces, you're going to get it reduced on the table if you put her in prone. This is a great. She's got a great retroperitoneal corridor. Her psoas anatomy is favorable. She'd do very well with a lateral interbody fusion, and then I would always stabilize this from the back. And whether you want to go from 4-1 or just do 4-5 is dealer's choice. But this is going to be a happy patient, and speaks to the power of just using positioning to achieve your alignment goals.
My colleagues in the South Sound, so Dr. Scovey, Dr. Martin, clear case for a fusion, this sagittal translation, this kyphosis, and is this a role for an anterior interbody fusion or oblique or lateral interbody fusion, or is it a posterior vision in your hands?
Posterior, because I'd like to do a decompression directly, and I think this is one of those cases that will do well with, I think, multiple approaches. Mm-hmm. You do an X-lift or a T-lift, bilateral cages, or you should be able to get a good result.
I don't know all the details here. I would actually think about doing an interlaminar spacer if the posterior elements are intact, just to say, but not totally sure about that. That's a little bit of a reach, but I would contemplate it.
Okay. Yeah, it's reasonable to bring up motion sparing. I think with that much facet edema, and the prior surgery was an A-lift, there's no posterior changes, so you certainly could, yeah.
But I don't want to sell it to the patient. And again, just looking at the translational images, the more standard approach would be a fusion. I have no doubt about that. So, drum roll.
So the patient did undergo left-sided prone transpsoas interbody fusion at L4-5 with posterior navigated percutaneous instrumentation. And we did go L4 to S1. These are her 6-week post-op films. And then here are her 3-month post-op films. I think in retrospect, the fusion had done so well at 5-1 since 2005. We did not obtain a CT, but I certainly would in my own practice. And I think that would help me decide about going to S1 or not. She has such, it may have been reasonable just to go to 5, given her parameters were already set, but I don't think there's anything wrong with this, like you said, Dr. Lockey.
So was this a prone, lateral?
This was a prone left-sided transpsoas, and then percutaneous posterior fixation, yeah.
And the patient did well for half a year so far?
Yeah.
So, Drs. Martin and Covey, you're younger surgeons than I am. What does the concept of doing a prone lateral surgery at the same time as you can do a percutaneous posterior surgery mean to you? Is that something that's cool, that's enticing, or a bit scary?
Well, we're not that much younger than you. I think it's attractive. I like the concept. I love being able to get that anterior column support. I think that there's so much contact there, and the alignment's great. And not having to monkey around with flipping. I think the advantages to doing it this way as opposed to minimally invasive interbody is that you're much better able to prep the disc and more likely get a fusion up front. And when the nav's working and it's accurate, it's slick. I think it's a great technology.
Quality discussions, Dr. Lockey, is this the ideal case for a same day, same setting prone lateral?
I think so. This is a great indication for it for this highly unstable spondylolisthesis. You're going to get great alignment and reduction in the prone position, and then it's just a stabilization procedure after that. Well done.
Approval, Dr. Minisali. Very good. All right, we're on time. Thank you to our 4 fellows for their cases. And kudos to my partners, Dr. Amir Abdul-Jabbar and Dr. Askuian, who provide these cases. Great honor and pleasure to introduce our guest speakers today, Dr. Stephen Lockey, Assistant Professor at Orthopedic Surgery at the University of Virginia in Charlottesville, Virginia. Great family man, great thinker, and has already made a huge impact. By means of background, he has an MBA from the Georgetown University, and he was an Alpha Omega Alpha Medical Honor Society student. He did his residency at Georgetown and was the academic chief resident. He did his fellowship with our colleagues at the University of Maryland, who are frequently participating here. And he also received the Distinguished North American Spine Society Traveling Fellowship. And in this capacity, we are honored to host him together with the Rothman Institute in Philadelphia. So we got to see him up close and in action. It was really cool to meet this bright young man who will undoubtedly be a leader, already is a leader, but a true leader in our field that we so need. And he has brought with him Joyce Wang, an MD, MBA candidate at Georgetown, and she's a research fellow with him. Great choice, Dr. Wang. And he's taking this topic that scares an older guy like me, the prone same-day surgery, to try to be efficient and safe and get all the check marks of realignment and stable fixation with high healing rates further discussed. And I know him to be a critical thinker, so I'm very curious to see how he can convince me, the old fogey. And I'll put Dr. Covey into that vein also, because he spoke exactly how I would. I just want to do these things posteriorly and can do a good job with that. But I'm curious to hear your thoughts on how this prone lateral same-day surgery can be a big advancement while doing it safely. So thanks for taking on this topic.
Thank you so much, Jens, for the very kind introduction. And I just want to say hi to you and all of our colleagues out at the Seattle Science Foundation, and just mention how grateful I am to see you again and to be back here. And we're very excited to host Dr. Chapman here at UVA next fall as visiting professor. You don't have to look far when you come to UVA to see the impact that Dr. Chapman, Dr. Skurian, Dr. Abdul-Jabbar have already had on our institution. And, it's an honor to have a chance to speak with all of you about my experiences with prone lateral access to the lumbar spine. I'd like to start by saying that I'm only, 2 years into practice, so I don't want this talk to serve as some kind of advocacy pitch for a technique or technology, but just mention how I've found this to be powerful in supplementing my practice, and some key lessons that I've picked up along the way. And I just want to start by also crediting Joyce Wang for helping put together these slides. She's been an outstanding clinical research fellow and is currently applying for her orthopedic residency. So, and then to begin, right, we know our audience. Jens, I look at your work with great admiration, and you once said to me, stay out of the retroperitoneal space. So I just want to emphasize that nothing replaces controlling the spine from a posterior approach. It's always the fail-safe in revision surgeries, and it stood the test of time and is the gold standard, and I'm not here to change that. Steve Ludwig, who trained me, said, when you think about the spine, you have to first consider the neurology. Every decision flows from that initial consideration. So a patient comes to you with arm pain, they come to you with leg pain or neurologic decline from spinal cord compression. We decompress the neural elements. If there's instability, we have to perform a fusion or stabilization. And then if there's deformity, we have to correct the alignment. And there's really only 3 ways to correct alignment. We lengthen the anterior column, you shorten the posterior column, or you do a combination of the two. However way you want to do it, it doesn't matter. But we shouldn't use these newer techniques to take shortcuts, or we end up with x-rays like this and unhappy patients that show up in Jens's clinic needing a revision. So I think these x-rays demonstrate, right, that if we stray from our foundational principles, it simply doesn't matter how big the incision is if we fail to decompress, adequately stabilize, and restore alignment. And I'd also like to say, I don't really view these options as minimally invasive when patients have shark bites like these when leaving the operating room. Our goal should be, in sticking with our foundational principles, can we achieve successful decompression, rigid anterior column stabilization, and correct deformity through less incursive means. And the reality is, I do think this technique of prone lateral is powerful. It's absolutely here to stay, right? And so we should have discussions about it, and we should train residents and fellows to be thoughtful in applying the technique when appropriate. You know, and my division chief, Dr. Shen, Frank Shen, my boss, who's been a tremendous mentor and has taught me a lot about the spine, sat me down when I started. He said, I don't care what you do, but it must be safe, reliable, durable, and efficient. And I'll tell you, having implemented this technique and technology in my practice, I found it through very careful consideration to be safe, reliable, and efficient. But I would never say, you know, a year and a half, 2 years in, that something is durable. And the other thing he told me was, you can do anything you want when it works, right? It's when it doesn't, it becomes a problem. And that's when it shows up in people, you know, clinics who do complex revision like Dr. Shen and Dr. Chapman. So this is just a quick outline. We're going to start with a case scenario, and I'm going to let Joyce, our clinical research fellow, quickly take us through this case. Thank you, Joyce.
Thank you, Dr. Lockey. So we'll start with our case presentation and then return at the end with our final treatment plan. But in summary, this is a 61-year-old male presented with severe back and bilateral leg pain. He's a former high-level athlete, but his current condition has left him pretty much incapacitated. He walks down the hall with 2 canes to support his posture and is leaning over the exam table during the encounter. He's tried and failed extensive conservative treatment without success. Unfortunately, he was struck by a motor vehicle about 1 year prior, requiring multiple X-laps. And his exam was relatively benign with full motor and sensory function in bilateral lower extremities. Next slide. So this was his CT scan showing multi-level vacuum discs and the L5S1 ismic spondy with anterior osteophyte and near autofusion at this level. And his MRI here is consistent with severe multi-level canal and neuroforaminal stenosis, contributing to his severe neuropathic leg pain. And these were his scoliosis films. You can see his stands with decompensated sagittal imbalance with a large PILL mismatch. He also has an L5S1 ismic spondy and a lumbar flat back with a dextroscoliosis and a left trunk shift.
So I want to talk a little bit about why even perform interbody fusion. When we get away from these core concepts, I think it's when we get into trouble and encounter the type of care that Jens was showing us in that previous slide. Interbody really comes down to the idea of adding rigidity to the motion segment. And you know, fusion is a tall order. You remember this is a classic article that looked at motion that occurs within a segment following graded resections. And so when we do a large circumferential decompression, we contribute inherent instability to that segment, particularly if we don't preserve the midline. And so if we are in a position where stabilization becomes necessary, you know, I spent 5 years in orthopedic residency trying to figure out how to get a bone that was previously united before a fracture to get it to heal again and prevent non-union. You know, we're taking 2 bones that were never meant to be united, that have a soft tissue component in between, and get them to fuse, right? And they have inherent motion between them. So it is a tall order to get a union, and this is just a recipe for pseudoarthrosis if we're not careful in our considerations. So, and I have to go back to this because you know, when I was trained, it was really hammered into me and by all of the fellows at Maryland, that you never stray from the core foundation of what we've accomplished as spine surgeons. So I was taught the basic indications for an interbody device are to improve alignment, add rigidity to the motion segment, which is key if you think about a stable construct to achieve fusion, and then adding biology and contact surface area to achieve that fusion. And finally, it does provide some indirect decompression of the neural elements, but I'll say in my training, this was always a secondary benefit. We were looking at an MRI once in clinic. I was with Steve and I said, oh, it needs a fusion bad for foraminal stenosis. And he looks at me and says, dude, that's what a Kerasim's for. You know, and like any new technology, the development of interbodies really came from a deeper understanding of spinal biomechanics. Those biomechanic principles included stabilization of the motion segment, but also understanding of alignment. And alignment is not just important from the standpoint of our cone of economy and good outcomes following sagittal correction, but also from the standpoint of successful healing. If the spine is balanced, if it's harmonious, each motion segment should see compression when a patient is standing upright. If the patient's unbalanced, then the motion segments experience shear, and we understand shear to be very bad for healing and for the adjacent segments above a construct. So interbody technology allows us to provide motion segment rigidity and improve alignment so that each level is seeing compression to achieve fusion and a durable result. And it's not surprising that if you look back at the historical literature, the first proposals for anterior column support came out of management of isthmic spondylolisthesis. Surgeons understood there was a tremendous amount of biomechanical stress in these high-grade spondies, and there was disadvantages to posterior-only bone grafting, not to mention this obviously is before modern fixation techniques. But this paper is taken from the 1930s, where the author states that while patients ultimately benefited from surgery due to the tremendous amount of shear, slippages inevitably progress, resulting in long-term poor outcomes. This is the first paper that just proposed anterior grafting of some type of circumferential fusion at the lumbosacral junction. And this technique was ultimately then performed. This is the origin of the later Bowman technique. And in this, this is a very brief summary, but Burns describes having performed the operation first on 3 cadavers. Then the first patient was a 14-year-old boy, where they did a transperitoneal approach. They took graft from the tibia and placed it through this bone tunnel between the L5 vertebra and the sacrum, and the patient went on to successfully heal. So while not an interbody per se, this is the first case to support anterior column rigidity and bone grafting to achieve fusion, even in cases where a segment is observing or a segment is impacted by shear forces. And then on the right-hand side of your screen, you can see the described Mercer method, where discectomy was performed and then iliac crest bone graft was placed within the disc space. The author mentioned in the original paper that the graft needs to be secured by screw fixation because upon lifting, the patient from the table was noted that some of the material extruded out. So following the operation, the patient would then be in a shell for 3 months and then bed rest for another month after. So, fortunately, we've come a long way since then. And then in the 1940s, there was this initial discussion of performing interbody fusion from a posterior approach following decompression of the canal and resection of the spinous processes. And this paper described taking a spinous process and then wedging it in between the vertebral bodies. In addition, just look at the degree of resection of the posterior elements. Essentially, the entire lamina pars and the 5-1 facet joint is gone here, and then the bone graft then laid down into the gutters. And so with time, we understood the importance of anterior column support for motion stabilization, successful graft placement, and restorational alignment. There's always been this quest, however, for access. And as a spine surgeon, you can reflect on the last 100 years or so of the field, and despite many new technologies, that basic foundation of what we do, it just has not changed. All that has changed is the instrumentation, the access, and perhaps the advent of enabling technology. But our understanding of alignment, spine biomechanics has allowed us to use these tools and the concepts that have been present in the last century more effectively. The journey of direct lateral access for interbody fusion is simply another example of technique development to achieve the same goals via an alternative and sometimes more favorable approach in an appropriate case, okay? And that journey to gain access has provided us with several approaches to the lumbar spine, all of which have their advantages and disadvantages. For example, some of my partners here at UVA use the anterior to the psoas approach, which obviously provides for a reassuring margin of safety from the lumbar plexus, but you're in close proximity to the great vessels, and you're ultimately working in what I would say is a non-orthogonal plane, right? In my mind, you want to work in a normal, that is a 90-degree angle to the spine. We control the spine from a posterior approach. You simply cannot get away from that fact. And I firmly believe that if we are abiding by the basic principles of our field, you need to have direct access to the posterior spine. And then if you want to work, you work in normal to that sagittal plane, which allows for a more reproducible operation. And I'd be remiss if I did not show this classic article published by Dr. Taylor and Dr. Pimenta on the development of the transverse approach. These authors deserve a lot of credit providing us with a novel option and working out the technique to create a safe corridor. The original article discussed a 2-incision technique to create a potential space in front of the quadratus lumborum prior to accessing the disc through the psoas muscle. And with this approach, you can provide a large cage and grafting material to the anterior column. So when you think about how does this approach enhance what we do, it does not allow us to cheat or violate the core principles of spine surgery. We use this tool to place a larger cage, thereby increasing motion segment rigidity. We use this tool to increase the amount of graft delivery, thereby increasing the biological environment needed for fusion. And we use the technique to maximize lordosis and correct coronal plane deformity when appropriate, not to cheat and take shortcuts. It's worth saying, though, that there are limitations to direct lateral interbody fusion. You can see here there are limitations, particularly when you get into discussions about prior history of surgery or unfavorable psoas anatomy. And I know Dr. Chapman's sitting there thinking, I could accomplish all the same goals and from a posterior approach, and nothing is going to stop me. I don't even have to think about these things. And he's right? But direct lateral interbody fusion does not replace what we do from the back. My argument is just simply, it's an opportunity to enhance what we can do in select cases. And I would argue there are considerable advantages to direct lateral, as I mentioned, including a larger cage and good apophyseal ring coverage, enhancing bone grafting, and perhaps the ability to achieve more favorable alignment. Notice how in all those considerations, I never mentioned less pain, less blood loss, or shorter hospitalization. When we focus on these advantages, which you could argue they do exist, right? More MIS, shorter recovery, but I think it may bias us into using these techniques when they may not be appropriate. So if you focus on the key goals of the surgery, which is decompression, rigid stabilization, restoration of alignment, and then apply your access tools to achieve those goals, you'd be less likely to create x-rays like the ones that show up in Dr. Chapman and Dr. Shen's clinic, okay? And remember, as someone who is traditionally trained, I always think about decompression from interbody as a secondary benefit, almost like an insurance policy, that we've done everything possible to address the patient's stenosis. But this study does demonstrate there's excellent foraminal height restoration with direct lateral interbody fusion. And if you look at the right-hand table, the improvement in anterior disc height suggests there is segmental lordosis achieved with this technique. And these findings bore out when the data was combined in this meta-analysis published in 2024. Direct lateral interbody fusion not only achieves foraminal height restoration, but statistically significant improvements in both segmental and overall lumbar lordosis. And I put this slide up as a comparison, not to say that any one technique is better at achieving restoration. I've been to Seattle, right? I was a traveling fellow. I've seen Dr. Chapman, Dr. Scorin achieve great restoration of alignment through TLIF, which again has the advantage of never being wrong. The key for the young audience and the fellows is what works best in your hands, okay? Can you achieve the patient's alignment needs, and what approach works best for you as a technician in that scenario? And there is a complication profile that's unique to direct lateral surgery. We are working sometimes in a narrow corridor. The abdominal viscera is directly ventral. This meta-analysis found that the most common complications were transient neuropraxias, such as tingling in the LFCN distribution, as well as thigh pain. But there are reports of more serious complications like a quad palsy or an anerotomy, which is something that we absolutely do not want. And I cannot have, I always tell our residents, I cannot have an anerotomy, I cannot have a vascular injury, and I cannot have a quad palsy. I can deal with a little post-op weakness that'll get better from a traction neuropraxia, but a full palsy is devastating, right? I cannot have it. And this slide deserves a big asterisk because certainly there is cost savings and reduced hospitalization and perhaps early discharge home. But what about the long-term costs associated with poorly performed or poorly indicated surgery? Revising an MIS procedure is certainly expensive, but more importantly, a morbid operation for the patient to undergo. So while we do need to be cost conscious, I'm always wary of these studies because it's not uncommon for administrators, most of whom have never taken care of a patient, to look at the short term and then dictate the type of care that we should deliver, okay? Now for the most important part, which is the prone position. As someone who is traditionally trained, I love operating on a patient who's prone because it's familiar. I have simultaneous access to the posterior column, which, as I said, we need to have direct control over as spine surgeons. Otherwise, we're not achieving our aims. And prone is always the position that ensures we maximize the opportunity to achieve our alignment targets. And this slide summarizes those advantages. In addition to simultaneous access and familiar position, I can take advantage of the bed to accentuate the patient's lordosis. I bump the hips up as much as possible, which also places the psoas muscle under tension, and simultaneously access provides the ability to perform posterior column osteotomies, which we want to do beforehand. Before placing the interbody, we can get more lordosis from our interbody cage. And there are a number of key points here that motivated me to take on this technique early, which is that it's a familiar position, simultaneous access, efficiency of care, and then robust power in being able to perform posterior column osteotomies and then introduction of the cage. And this study summarizes the lordosis we achieve when placing the patients prone. Remember, 50% of our lordosis comes from 4-to-1. And so placing the patient prone with the hips extended can dramatically modify our alignment before we even make an incision. If there's any instability or spondylolisthesis, the prone position will also provide for some degree of reductions. There are many advantages to prone in terms of alignment that go beyond just placing the patient in a position that's familiar to the surgeon. This radiographic study supported the theoretical discussion on the last slide, which is that when performing direct lateral interbody fusion in the prone position, we do see more favorable alignment targets. You can see that PTP was superior to achieving global as well as segmental lordosis in the lumbar spine, and there was lower postoperative pelvic tilt when compared to dual position direct lateral. I always talk about what I cannot have, right? And I mentioned that earlier. You know, when you start practice, I think like one of the most important things for the fellows who are about to go out and have just amazing careers is you want to demonstrate to your anesthesia staff, you want to demonstrate to your patient, you want to demonstrate to your OR and to your hospital that you have a commitment to patient safety, right? And I cannot have a bowel injury, I cannot have a vascular injury, I cannot have a quad palsy. I scrutinize each step of the operation to mitigate risk. And the nice thing about prone is that it does, in some cases, increase our margin for safety. This study determined greater distance between the anterior margin of the disc and the great vessels when the patient's prone, which again, the risk of vascular injury is not something I'm willing to tolerate. And then there is some debate about the position of the peritoneum when the patient's prone versus lateral decubitus. I tell the fellows, we are not going to have a bowel injury before every prone lateral case. We scrutinize the MRI, and if we have any concerns, we always directly visualize the psoas prior to placing a dilator. This is a more recent study that actually determined the working quarter within the retroperitoneal space was narrowed when the patient's prone compared to lateral decubitus. And so I think we need to say, you have to be careful. Injury to the bowel is rare, but you should strive for an end of 0 in your practice when you do these operations. And I'll discuss some of my personal safety pearls later on. And the complication profile when you look at PTP is overall very similar to reports of direct lateral, which is expected. But I would just mention particular attention to inadvertent ALL release, which can happen, particularly when working at the apex of lordosis. Patients with good bone quality and with sequential dilation, you'll not infrequently hear and feel the ALL rupture, which usually is not a problem, but in these cases, will supplement with a lateral plate fixation in these cases to avoid plate migration. In this talk, we've touched on the goals of surgery and using lateral interbody fusion to achieve alignment targets, but what does the literature actually say in terms of deformity correction? This is a case example here where the patient has severe coronal plane deformity, and through a single incision lateral approach on the right side, the surgeon was able to perform multi-level access fusion and concave-sided interbody distraction to correct the coronal plane. And we do see benefits to direct lateral interbody fusion in achieving spinal pelvic harmony. I would point out in the second set of bars, look at the pre and post operative Cobb angle. Now, this was before this paper was published well before Dr. Chapman was showing us the power of intradiscal osteotomy on a unilateral side of concavity to correct coronal malalignment. But I do think direct lateral provides a lot of power in this particular side when you approach the deformity from the concave side. This was another paper published in 2020, which compared radiographic outcomes between posterior and lateral approaches to interbody fusion in patients with adult spinal deformity. There was not a tremendous benefit to direct lateral, which confirms what we know, that good technique with a T-lift can achieve our alignment targets. But do take note, the coronal plane correction was significantly better in lateral interbody fusion, pointing to the power of this approach in a combination with other techniques. The authors also noted, I think this is really important, is that posterior column osteotomies were key to achieving added lordosis when the lateral interbodies were placed, which again speak to the power of being prone and having direct control over the posterior elements. And finally, this is a meta-analysis that summarized the findings, and the authors found that lateral interbody techniques did seem to achieve better sagittal and coronal alignment targets compared to more traditional approaches. But I would say this is controversial and highly surgeon and technique dependent. The key here is that you're thoughtful and safe. Lateral interbody fusion can help you achieve your alignment targets for your patient if you're not comfortable performing a more aggressive style T-lift. like an ALL release, okay? We simply just need to get the job done for patients, and whatever tools you have to effectively achieve that goal is what you should use. And because PTP is relatively new, there is still a paucity of data on the impact of prone lateral in deformity correction, but the power really comes from these adjacent segment studies. When you have adjacent segment disease where you get simultaneous access points during treatment to the spine, it can achieve excellent correction very efficiently through these junctional issues with minimal morbidity to the patient. So this is another case example of severe junctional disease and flat back deformity treated with a L3 to 4 PTP and posterior column osteotomies with an extension of fusion. This is an example where you have a potentially very challenging problem, right? A lot of scar tissue working in an adjacent segment. And doing dual position surgery or an all posterior approach can be burdensome, but with appropriate positioning and dual access and working through a native window, you can achieve excellent correction and hopefully minimize morbidity for the patient. This study was just published last year, demonstrating significant improvement in radiographic parameters with prone lateral interbody fusion. Again, we see evidence of better correction with lateral interbody fusion when compared to other techniques, specifically in the coronal plane. So the position of this talk really is about, this portion I wanted to go into my personal safety pearls for the trainees or people who are thinking about adopting the technique or technology. This is more my opinion, so just take it with a grain of salt, but ultimately this is a combination of things that Luis Pimenta taught me, Dan Kavanaugh, Ryan Stuckey, who's down in Houston, that have helped me to adopt this with a degree of comfort and implement safe and I think effective care when I've used this in appropriately selected cases. So, when I think about initially adopting the technique, if you're going to approach and do a prone lateral interbody fusion, you're thinking, what is the right way or what's the right case? You're looking for a case. It always comes down to the initial surgical indications of decompression, stabilization, restoration of alignment. You don't want to cheat and use a lateral interbody fusion, but if you think it's indicated in that context, then you start to look at these parameters. And what I did always is look from the outside in these first select cases. Can I take my finger from the skin incision, go straight down to the psoas and the disc space, and never encounter the bowel? I think that's a really important way to start because you do not want an enterotomy. And when you're prone and you're working in this corridor, visualization can be difficult. So this was sort of the first type of case that I did. And then I always look at the psoas anatomy. I don't want a psoas that's too ventral. That obviously is a concern for a more ventral lumbar plexus, placing the femoral nerve at risk. And then I always look at the vascular anatomy. I scrutinize, is there a fat stripe? What's the position of the IVC? I tend to always work from the right side because I want to control the IVC and work away from it. My angle or degrees of freedom is going to allow me to work from patient right to left and have lower risk of a vascular injury, in my opinion, if you have control of the anterior margin and then you work across. This is another example. There's obviously a tight retroperitoneal corridor here. This is one I did later in practice as I gained more comfort, where you enter the retroperitoneal space, you hook your finger posterior, you feel for the quadratus lumborum, you work your way ventral and sweep everything out of the way. And often, if I have any hesitation or concern, I will place a lighted Wiley handle over my finger and directly visualize the transverse fibers of the psoas muscle before I even place a dilator. That gives me a high degree of confidence, even in these patients who don't have much retroperitoneal fat, that we don't have any bowel in the way. And then in this case, I also would just point out, look at the IVC. Now, not every lateral surgeon talks about this or thinks it's a major concern, but there's a little draping of the IVC here. In my mind, if I come in from the right side, I dock on the anterior margin, I use two shims, I control where the IVC is, I have control of the nerve and drop a shim so that I know it's behind me. It then becomes a procedure that I can watch. And it's a great surgery for learners because I have control of everything bad. I work parallel to the floor, perpendicular to the disc space, and then my hand is working in a way that's orthogonal to the tilt of the C-arm so that I'm not violating the disc space with each of my instruments. And I actually can watch the trainee do each of these steps in the position of their hand very comfortably and let them do the surgery once we've controlled all those factors that I mentioned as a major concern. And that's me. So here's our case presentation. Joyce, I'll turn it back over to you to bring us home here.
All right, again, we have our 61-year-old male presenting with severe back and leg pain, difficulty standing upright. His exam overall, motor and sensory intact. Next slide. So his pre-op scoliosis films demonstrating severe decompensated sagittal imbalance with coronal shift, as well as L5S1 ismic spondy. And for the sake of time, I'll skip the CT and MRI again, but recall that we have an L5S1 ismic spondy with bridging anterior osteophyte. He also has a history of multiple XLAPs prohibiting a direct anterior approach for this particular case. And so we performed a T11 pelvis instrumented fusion with posterior column osteotomies and L2 to L4 PTP, L4 S1 TLIF.
So this is just a slide. I centered on L3, my incision, and then almost like a beachhead, you come in and you start at the more distal level, control all of the structures that we're concerned about, and then you basically, through a distraction interbody technique, can lift up this coronal plane deformity all through a single incision, breaking through those osteophytes on the lateral margin. And before you've even opened up the back of before you've even opened up the posterior approach, you have good correction, good anterior column support without having very little blood loss. So go ahead, Joyce.
So here are his final x-rays, and you can see restoration of sagittal balance. Next slide. And here are the alignment parameters.
So, and just in critiquing myself, I probably undercorrected him a little bit here. We had a lot of challenges down at the base. There was that bridging osteophyte. And like I said, in this case, I would maybe like to have done an anterior, but that was not an option given his multiple XLAP history and our access here. So we did do TLIFs, and overall, he's done quite well from this. And, we're able to trend some of his imaging over time, and he's now walking upright and quite happy with his outcome. But more to be determined. As I mentioned, being a year and a half, 2 years in here, I would never comment on the durability of a result. But so far, a happy patient, and we'll continue to follow him. So I just want to say thank you again for the opportunity to speak with you all. I think a lot of the value that I can deliver is not going to be so much to the senior surgeons, but to some of the younger folks who are starting or the trainees who are just coming out. As you think about implementing a new technology where you're going to a hospital where that technology may not be introduced yet, and you're bringing it there from your training institution, there are some considerations you have to bring with that. And always, 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 safety, patient safety is the most important thing.
Fantastic. Beautifully done case. So one question that I had is, what are your thoughts on the psoas survival, especially if you do multi-level far lateral procedures? Is that psoas still viable at the end of that? Or is that just shredded filet mignon?
Yeah, I think there's some good evidence that we see a lot of psoas atrophy, particularly after multi-level trans-psoas approach. I think ultimately, fortunately, there's some redundancy with the iliacus in terms of hip flexion. I'm not sure it makes a clinical benefit. That hasn't really shown, but certainly there's some denervation and significant atrophy after a direct lateral. The other thing is, though, you see that not too often. I'm sure you've seen MRIs, Jens, of your patients who've had a total hip in the past, and it's not infrequent that you see a tremendous amount of psoas atrophy, and they're doing just fine on the ipsilateral side of their hip replacement.
So we actually have two studies on that. One was neurologic deficits, which showed that there's a far higher incidence than previously reported by Dr. Uribe et al. So I think we tell our patients there's a 9% risk of some at least temporary significant lumbar plexus decrease. But who of the fellows can talk about Luke's study? Is one of you willing to extrapolate on that? We have a young research scholar, and he's actually measured the psoas in an amazing fashion. Dr. Kramer, are you willing to talk? Dr. Minnesota is busy putting his banana peel away.
So it's a very well-done study that's basically looked at ipsilateral and contralateral muscle size and quality pre and post trans-psoas approaches. And the data suggests that at least some patients seem to have a fairly significant atrophy after these approaches, but on the average, it does seem like the muscle actually, at least in comparison to the ipsilateral side, doesn't significantly change. So it's, I think, a positive study from the standpoint of lateral surgeons.
So yeah, we found this to be actually surprisingly good. And what you mentioned about the psoas size, it is actually pretty cool to see how Luke measured the recovery of the psoas as a phenomenon with increasing activity level afterwards. So even on the non-involved side, that's impressive to see. So this is a very dynamic muscle. So we were kind of excited about that. I think it's hopefully going to go to peer review or has just been submitted for peer review. He presented at the Global Spine Congress. We're at time, but 1 second, Dr. Davis had a question. So first of all, Dr. Kavanaugh would have been proud of you. Oh yeah, let's talk about that. This is a really cool topic. Dr. Randy Davis brings it up. Any reports of pseudoparalysis of the abdominal muscles with hernia? He's had problems with this. I've had problems with this. I have my own thoughts about this, but would love to hear your observations on that.
I've not had a pseudo hernia yet. I think I always talk to patients about it. I think it's coming. I think we get it, and it's I'm pretty meticulous with the closure. I try to close the muscle layers and the fascia, but it sometimes is not preventable. And I did see one as a fellow as well, and that it ends up being a problem, but something that general surgeons can fix. I haven't seen one yet, though.
Yeah, so this is a great question because actually general surgeons can't fix it. It's not a hernia, it's a paralysis of a dominant, probably 11th or 12th nerve root to the obliquus. And so they get this lateralization of the umbilicus, and they think there's a hernia, but there's no hernia. Actually, it's just a denervated obliquous system. And it's a dominant, Shane Tubbs showed that in a couple of lab specimens. It's a dominant nerve root. At that, so there's no reefing, no mesh or whatever you can put in there to fix that. It's basically a visual stain, and again, it's a disrupted 11th or 12th nerve root that somehow in those patients is a dominant one. One more question we have to run, although we could talk about this. So really cool talk, great overview, and then going into this new era. Left versus right. So talking about disasters, MIS is fantastic if everything goes well. If not, we open up the gates of hell sometimes. So we had a patient a couple of years ago where a far lateral procedure was done on the right side for degenerative scoli. It's not a PTP, but it was a standard sequential lateral. And I think there were 2 levels done from the left, 2 levels done from the right. The patient ended up with a colon perforation. From a far lateral, well-performed procedure. The colon is actually retroperitoneal on the right side for a small area right around the upper flexure. So right versus left, is it safe to assume that based on MRI study you have a good corridor? What are your thoughts on this, or should we just stay left?
I actually always go from the right side if I can, and that's controversial. Some people say don't do the right side if you end up having a quad issue. That's the driving leg. I like going for the right for the reason I mentioned. If you come off axis, particularly, I like taking a 3-dimensional surgery and making it 2-dimensional. If I have a 2-bladed system and I dock anterior, dock posterior, I have control of the vessels, then I'm just working across the disc space. But if your hand comes off axis and you have a draped inferior vena cava on the contralateral side, and you come off and clip the back, in my mind, that could be devastating. So I think the margin for safety from the vascular anatomy, I like going from the right. And if your neuromonitoring data isn't favorable, then you can always stop. But I found the neuromonitoring to be very helpful, reliable, safe, to make sure that I have good control of the nerve and then go from there.
We're at time. Thank you, Dr. Wang, for a really cool big picture and specific technique-oriented presentation. Very nicely done with that case demonstration that was highly educational also, and we appreciate your discussion of our various troubles and tribulations here in Seattle. So thank you, great to see you, until soon.
See you soon. Thank you for having me. Good to see everybody.
ATAC, here we come.
That's right. Big part of that is using.
Are you going to do PTP?
I think so, yeah. But again, just like him, not in replacement of,